India 2017 and Investigator of the Year award multiple times. So let's move on to the topic. Over to you, sir.
Thank you, respected chairperson. And this is a topic, innovation in insulin delivery for patients on insulin therapy. Sorry, they had to call me. I was rushing to the venue. And why in a meeting where we are talking about AI, we are talking about technology, automated insulin delivery systems, why are we talking about innovations in insulin therapy? And it is important to understand that even the basic steps of insulin delivery, they can go wrong, and how we can improvise the patient's experience in terms of insulin injection, insulin technique, and in terms of minimizing the complications of the injection therapy. So disclaimer, this is a talk which is sponsored by Gupta, and this is my slide, and this is how we are going to, this is the flow of the talk. We are going to talk about the technology innovation for optimizing insulin injections. What are the innovations in needle technology for proper injection technique, and education on proper injection techniques and training on injection techniques leading to improvised blood glucose control. So let us discuss about the technology first. We know that just a couple of years before we celebrated the 100 years of the insulin invention, and may have gone to the muscle also, leading to a different variable absorption of insulin and giving rise to hypoglycemia. So it is not just about the delivery, but it is making the experience convenient as well as the comfortable. At the same time, if the injection of insulin is given at the right place with the right technique, then the absorption will also follow the pharmacokinetics which actually the insulin is supposed to follow. So this is going to minimize the glycemic variability, and again, a patient who doesn't have any bad experience with the insulin injection is more likely to stick with the injection therapy. So this is just to show you the technology innovation. This is the first purpose designed reusable glass and metal insulin syringe, and then you can see the evolution of the insulin syringes. And this slide shows you the length and the gauze of the needles. So the new needles, most of the time which we are using with the pen devices, is a 32 gauze needle, and now some people they are also coming with the finer needles also. Again, the length of the insulin syringe needle, you can say, has changed from 16 mm in 1985 to it is 4 mm in 2010. So this is again a major innovation and major change in which the insulin needles have changed. So what is the technology innovation for optimizing insulin? One is the main challenge which is overcome by the innovations in needle technology is the shorter needle length. Also the increased bevel tip needle. So I will show you in the next slide that what does that mean. And insulin flow. So extra thin wall needle for the improved flow. So if you have a needle which is having more thickness, then the flow of the insulin is going to compromise. So sometimes the patient may end up not injecting insulin into the skin, but releasing the insulin drops here and there without adequate delivery of the insulin. Also, you know that thickness will also affect the force with which injection needs to be taken. So if a patient applies too much force and the gauze of the needle is very small, so there are chances that there will be droplets which will come out from the injection site. So sometimes a patient who is injecting a large dose of insulin with an insulin syringe and the needle, and if he uses a lot of pressure and injects it forcefully, then a large volume may also come out of the subcutaneous site and may not actually go inside. So how this innovation has changed? This is an important fact to understand, that we believe that if a fat person has come to us, if an obese person has come to us, then probably he will require a larger needle size. This is general perception. But scientifically this is not correct, because the skin, we know that the skin thickness even in the most obese people is almost going to be the same, and it is 2 to 2.5 mm thick only. So a 4 mm size needle can be good for a normally thin person also, as well as an obese person if you are looking at the subcutaneous fat. So a needle is long enough to, so a 4 mm needle is good enough to cross the skin into the subcutaneous tissue, but short enough to not enter the muscle. So sometimes just out of the curiosity, we believe that this patient is very much obese we may think of giving larger length needles, for example 6 mm, or maybe the older ones which are 16, 10 mm also, and this can lead to intramuscular injections of the insulin, which can be avoided with a small length needle. So this is just a diagram which shows you that the thickness of the subcutaneous tissue is almost the same, that is 2.2 to 2.5 mm, and the dermis, and this is how you inject the. So 4 mm needle reduces chances of the intramuscular injection. So 4 mm needles reduces chances of intramuscular injection. So needle length comparison trial, this was done at 4 sites in the United States, and the patient preference for the shorter 4 mm needles was something which was reported, and equal blood glucose control in the less pain. So shortening the length of the needle actually led to better acceptance of the insulin injection and avoidance of the injection into the muscle and less painful injections. So again, as we have discussed again and again, that there are reduced chances of intramuscular injection, and this slide shows you the preference for 4 mm needles with a confidence interval of the 95%. So which of the tests, so a question was asked, which of the test pen needle did you prefer on overall basis? So prefer 4 mm a lot more. This was the answer given by 42% of the patient, while the other answers, they were spread out in different categories. And which of the test pen needles did you prefer on an overall basis? And again, the question, 50% of the patient, they preferred to use a 4 mm a lot more in comparison to the other size needles. So reduced intramuscular injections leads to better glycemic control, better glycemic variability, and there are reduced chances of bleeding and bruising, as I pointed out in one of the clinical examples which I recently observed. You all must be observing this kind of cases in your clinical practice. So this is one area which I wanted to highlight. Again, insulin must be injected into the subcutaneous. We know that subcutaneous fat injection is very, very important for the insulin injection. We don't want to deposit into the muscle. So this slide again talks about the same point. So this is technique. This is the injection technique, and no intramuscular injection should be given. This is very, very important and interesting also. So there are factors which affect pain associated with injections, and these are multiple factors. So one of the major phobia of a patient while accepting the insulin therapy is the perceived pain with the injection. So if you tell the patient that injection is virtually painless, so what gives you that confidence that injection is virtually painless? So this is the designing of the needle which allows the injection to be virtually painless. So the needle diameter is something which is called the gauge of the needle. There is a needle length, then smoothness and the lubrication provided to the needle, and the sharpness and the bluntness of a needle. So these are the 5 different factors which define that how a needle is going to perform. So needle tips vary in terms of bevel design. So the design of the needle, you can say this is the needle which is the older 3 bevel. So 1, 2, 3. These are the 3 bevel which are there. And now you can see the more advanced designing where the 5 bevel are there. So what happens when you are using a needle which is having 5 bevel tips? It reduces the needle insertion force. So scientifically they have proven that a needle with a 3 bevel is likely to need more force and is likely to meet with more resistance when you are giving an injection, while a 5 bevel needle will pass more smoothly through the tissue with less resistance, and this will give you a better acceptance of the insulin injection and makes the insulin injection process more acceptable. So if 5 bevel tip versus 3 bevel tip, are there any studies? So in the study, the primary objective was to find out in paired insertion with the subjects blinded to pen needle tip geometry, 5 bevel pen needles were found to be non-inferior to 3 bevel pin needles studied. So patients strongly preferred the 5 bevel pin needle across all the 3 factors, whether this is the ease of insertion, the comfort, or the preference. So this study was comparing the 3 bevel needle with the 5 bevel needle, and they found that the 5 bevel needle, the acceptance, the comfort, as well as the preference was more to the 5 bevel needle, and they were blinded, they were not knowing which needle they were using. Also, you see the thickness of the wall of the needle. So in a 32 gauze needle thin wall and a easy flow extra thin wall. So when you make the needle extra thin, then the insulin flows more smoothly through this kind of needle. So this is very, very important. So again, this is a advances. As you see, this is again a change in the designing of the needle, and a thin wall needle is likely to be more suitable for a injection flow, which may sometimes, because you cannot teach each and everything to the patient, and even if you tell, they may use more force while injecting while taking the injection. So every time we tell our patient that you need to inject it slowly, not with a big force, because big force is going to lead to a faulty injection technique. So there is a less obstruction and overflow and ease of use of advantage. So this is something which is, I think, basic physics, but now the developers, they are bringing it to more and more to the forefront for the patient benefit. So if you look at this slide where we are talking about the extra thin wall needles, so if you talk about the overall preference, and if you look at this forest plot, you will find that all the parameters which are favoring a extra thin wall needle are towards on the right side of the curve. So overall preference, like which is the thumb force, full dose confidence, injection time, pain, ease of the insertion, and the convenience of the use, they are all favored by the extra 5 bevel needle. So this is very, very important, that education on proper injection technique, and whenever we are initiating a patient on insulin, or whenever we are reviewing a patient who has already been initiated or on insulin, every time when patient comes to us, it is important to review the proper injection technique, because over a period of time the patient will tend to lose the accuracy. They may be taking it, we have seen in our clinical practice numerous examples where the patient will be taking injection only at one side, despite the site being swollen, despite the site being painful, there are nodule formation, but the patient will still continue to inject at the same time because they have learned it wrong, and nobody ever asked that once they were initiated, then they are taking insulin. We never bothered to ask that how are you taking insulin, what are the sites, are you rotating it or not. So it is very important to tell the correct injection technique, and I guess we have some material here which can guide you that how to make the proper insulin injection technique, some graphs and some some material to assist you in injecting the insulin at the right place. So education on proper injection technique. So what are the common errors which are made? So several patients did not rotate injection site correctly, leading to lipohypertrophy or lipodystrophy at the site. Only 32% of the patient left the pen needle under the skin for the recommended 10 seconds or longer. So we want, once the injection is done, we want the patient to take out the needle slowly, because the insulin is still going inside. So we instruct them to wait for at least 10 seconds and take out the needle slowly. So they may be doing it in a faster way, and still the insulin is not delivered. And they will complain that they will be seeing some droplets at the tip of the needle. And 25% of the patients who lifted a skin fold did not do it properly, and less than 50% release the skin fold correctly. So lifting of the skin fold and releasing of the skin fold is again very, very important. So this is something which is very important that we teach our patients about. So less than 40% of the patients said they received injection instructions in the last 6 months. So this is not a good situation. And 10% claim that they have never received training on how to inject correctly. So look at the challenges with the insulin therapy. First of all, patient has a barrier. He doesn't want to initiate insulin. Second is that doctor also, they have a barrier. They don't want to give insulin because a patient on insulin requires more time, and patient also so you need to monitor more vigorously. Third, if such a patient is not given a correct insulin injection technique also, then the chances that he or she will not follow the regime, and they will simply drop the insulin injection. So if we can give proper training on insulin injection technique, so this can improve blood glucose control, and there are clinical studies to demonstrate that. So if a patient who is injecting insulin with a proper education can reduce HbA1c by 0.58% with the same insulin doses, with a drop in fasting blood glucose, as well as reduction in the total insulin doses which are required by the patient, and less weight gain also. Again, if you change in HbA1c after injection training technique. You can say pre and post change in HbA1c, and you can say that in group 1 and 2 insulin treatment regime, training on proper insulin injection technique, and you will find that there is an improvement in glycemic outcomes, lipohypertrophy, and adverse injection site reactions. So the important features are that the site rotation is very, very important. Needle dwell time, which is approximately 10 seconds, is again to be emphasized. Use of skin folds for needle which are more than 6 mm. So it is again important that it is not necessary that we ask the patient to make a skin fold with a 4 mm needle. So this is very, very important, probably because the needle is so thin that even if you don't make a fold, it will not go to the intramuscular space because the length of the needle is very small. So making a fold is not very, very important if it is a 4 mm size needle, but if you are using a 6 mm and above, then there are chances that the needle may go directly into the intramuscular, into the muscular plane. So that is why you are making a fold. For a 4 mm needle with a skin thickness of 2.2 to 2.5 mm and the subcutaneous fat there, the chances of going into the muscular plane are not at all. So clinical training is very, very important. Assessment of the patient, education, individualized training. Sometimes different patients may have different needs regarding their insulin injection technique, so we need to address that. So, and review patient and evaluate outcome at the appropriate intervals. So proper insulin delivery is key and proper technique is essential. So this is the new insulin delivery recommendation, which is an article published by the Mayo Clinic, and this is a study from the FITR guidelines from the Mayo Clinic, and they talk about the comprehensive guidance on insulin delivery informed by an international survey, that is the ITQ, conducted on over 13,000 patients with diabetes in 42 countries, and this was done in 2014 and 2015. And these guidelines were written based on the advice from 183 diabetes experts from the more than 50 countries. So this is the paper published by the FITR group or the FITR workshop. So what they recommended? So they recommended that avoid injections into the sites of lipohypertrophy, avoid needle reuse. This is again very, very common. Injection into the subcutaneous tissue is to be given, intramuscular injection to be avoided. Select appropriate sites for insulin injections, and these sites are shown in the diagram. And the practice site rotation, which is again most of the time. And this happens not because unintentionally, because for the convention, if you take anything on your abdomen, you are likely to hit the same point again and again. Whether you use the right hand or the left hand, again you are going to come at the same side. So to move it a little bit, you have to be cautious and doing it consciously. So few words about the lipohypertrophy. So lipohypertrophy, these slides shows that at the insulin injection site, you will find that this is the classical lipohypertrophy, how this site has changed. So absorption of the insulin from such a site can be erratic, and this can lead to a lot of issues, especially with the glycemic variability, hypo and hyperglycemia. So lipohypertrophy causes, what are the main causes? One is the reuse of the needles. If a person uses the same needle again and again, incorrect injection site rotation, and the longer duration of the insulin therapy can also lead to this. So I would like to conclude in time by saying that choose the right technology for a comfortable experience. Recommendations for the technique should be written in our prescription, and we should demonstrate injection technique to our patient, or at least we should train our staff and supervise them that how they are teaching the patient. We should review that. And education is a continuous process for all of us, including physicians as well as our patients. Thank you very much.
Thank you, Dr. Amit for that exhaustive talk and for diving deep into the proper insulin administration technique. So, to begin with, if you initiate insulin to a patient, it's always important to have a proper insulin conversation. Ideally, you need to demonstrate how insulin has to be taken and ask the patient to take a small shot of insulin in front of you to ensure that the patient is taking insulin in a correct, proper manner. And you can correct the patient if you find any mistakes in that. Thank you, Dr. Amit Gupta, for that enlightenment.
Thank you.
Is there any questions from the floor?